right. Well, I guess in the interest of time, we'll jump right in. I'm sure we're going to have a lot of questions along the way, and happy to entertain those questions as we move along. Just a little bit about today's discussion. We're going to be talking a bit about the trauma of Indigenous people, Indigenous intergenerational trauma, and how that plays a role in Indigenous health, looking at adverse childhood experiences, social determinants of health, and the Indigenous health crisis, as well as reconciliation in healthcare, things that we can do. So, a growing number of studies support the idea that the effects of trauma can be passed on to subsequent generations through epigenetics. And speaking of epigenetics, this is a picture of my daughter, Mackenzie, and I as babies. And I'm sure by the end of this presentation, you will have formed a decision one way or the other, that whether she was blessed with good genetics or bad genetics. But in 2013, researchers blew the scent of a cherry blossom through cages of adult male mice while zapping their feet with electricity. And after being zapped a few times, these mice associated the smell of cherry blossoms with pain. So these traumatized males were bred with females, and when those pups smelt the scent of the cherry blossom, they became jumpier and more nervous than pups whose fathers had not been traumatized. Well, maybe they learned this behavior from their parents. Nope, they were raised by unrelated mice who had never smelt a cherry blossom. And the second and third generation didn't fear the scent itself, but had a heightened sensitivity to it. And so the finding of this research supports a theory that the next generation doesn't always show exactly the same trait that their parents had. It's not the fear that's being passed down through the generations. It's the fear of a scent in one generation that leads to a sensitivity in the next. Now, another study went a step further. They extracted RNA molecules from the sperm of male mice who had been traumatized, and they injected them into the embryos of mice whose parents had not been traumatized. And the resulting pups, however, still showed those typical altered behavioral patterns of pups whose parents experienced trauma. Now, we'll come back to mice and cherry blossoms and whether or not the epigenetic effect is real. But I can tell you from my own personal and professional experiences that the connection between historic trauma and intergenerational trauma is as real as the rivers and the rocks. Michelle Sotero at the University of Nevada has defined trauma in 3 different stages. The dominant culture perpetuates mass trauma on a population in the form of colonialism, slavery, war, and sometimes genocide. In the second phase, the affected population shows physical and psychological symptoms in response to that trauma. In the final phase, the initial population passes these responses to trauma on to subsequent generations, who in turn display similar symptoms. And so throughout history, we've observed human responses to trauma, and you probably see how these phases of historic trauma are quite similar to the epigenetic responses observed in the cherry blossom mice. This is the now famous painting by Kent Monkman called The Scream. It's been called an undeniably visceral depiction of that exact moment people like my mother were ripped away from their family and their home and shipped off to residential school. In the 1950s, my grandfather, my mushum, spent 5 years in prison for killing a moose off the reserve to feed his family. And when he was released, he was deathly afraid of the RCMP and going back to prison. And so when the police and the residential school administrators came and took his children away, he said nothing. And after about a month at residential school, my mother and my Aunt Ginny ran away. And they made it all the way back to the trap line, through some 50 kilometers of northern Saskatchewan forest. Really harsh conditions for a young girl. A few days later, the police show up at the trap line with the school administrator. School administrator catches my 7-year-old mother, and he bloodies her nose in front of my grandfather. And my mom said that her father did nothing in her defense, and she never forgave him for that till she was in her 40s. She said it took her that long to figure out that they had broke him in prison, and that by the time he had gotten home, he had no fight left in him. He knew that he was powerless against the police and the government, and so my mother was taken back to residential school. And so this is my mother. My mother's name is Ivy. Her Cree name is Eagle Whistle Woman. Ivy is a Cree woman from Montreal Lake Cree Nation. Ivy suffered every kind of child abuse imaginable in the home that she was raised in at the hands of other people who had come back from residential schools. And she suffered more of the same when she went to residential school. As an adult, she suffered 2 years of domestic violence. She had struggles with PTSD, anxiety attacks, depression, and suicidal thoughts for most of her adult life. And to cope with trauma and emotional pain, Ivy self-medicated with substance abuse for many years. At 32, she left an abusive partner and went back to school with a grade 9 education, finished her GED, and now a single mom with 3 hungry kids, she went on to university. At 35, she found Indigenous culture and she adopted a traditional Indigenous lifestyle free from substance use. And after finishing a bachelor's degree in social work, she went on to finish her master's. She's been a successful, self-employed mental health therapist for over 20 years. She's traveled all over the world, achieving many of her dreams. And my mother's story is one of strength, courage, and hope. I mean, she personifies resilience. But as you'll see, she's an exception rather than the rule. My mother's traumatic childhood is not unique. Indigenous people have been exposed to over 120 years of colonization and assimilation policies, and the legacy of those policies continue today. Over 150,000 Indigenous children taken away from their families, placed in residential schools. The odds of returning from World War II were 1 in 26, and the odds of dying in residential school were 1 in 25. Thousands of residential schools recalled incidents of physical, emotional, and sexual abuse, underage pregnancy, starvation, malnutrition, torture, and even murder. The 60s scoops of 1960s meant another 20,000 children taken away. The millennial scoop meant another 22,000 children taken away. And the modern child welfare state currently has 53.8% of all children in care being Indigenous. On July 4th, 2021, the Honorable Dr. Carolyn Bennett is quoted as saying, "There are more kids in care now than there were at the height of residential schools. It's unacceptable and it's harmful." But to understand how all this trauma affects people like my mother, we need to first appreciate the health consequences of adverse childhood experiences. And so if you're not familiar with adverse childhood experiences, this is a crash course. Between 1995 and 1997, Dr. Vincent Fellitti leads a study of over 17,000 adults in California. These participants completed confidential surveys regarding their childhood experiences with physical abuse, emotional abuse, sexual abuse, and the other traumas listed here. But the more trauma they had, the more health problems they developed. Essentially, a child survives a traumatic adverse childhood experience, is exposed to toxic stress. The child has disrupted neurological development in response, struggles with social, emotional, and cognitive impairments. Now that child doesn't fit in with the other children. Later copes with these difficulties through high-risk behaviors, like substance use. Over time, this leads to chronic disease, disability, social problems, and ultimately an early death. The presence of high ACE scores in childhood are now commonly associated with higher rates of obesity, cancer, diabetes, heart disease, COPD, higher rates of addiction and mental health, incarceration, and even homelessness. But understanding the Indigenous plight goes beyond learning about residential schools, and it goes beyond learning about adverse childhood experiences. It's about understanding the cycles of trauma that they started and the effects on Indigenous health. My mother had stopped the substance use. She had left an abusive situation. She went back to school. She found her spirituality and her inner strength, but by then the damage was done. Like my mother before us, all 3 of us score or would likely score 10 out of 10 on the ACEs survey. We grew up in an extremely dysfunctional household with an extremely abusive stepfather. Substance abuse and domestic violence were commonplace. We suffered many forms of child abuse and neglect. And we grew up in an unpredictably violent place, devoid of any safety, structure, or stability. We experienced extreme poverty and food insecurity on a daily basis. And now my mother had the same childhood as her siblings, and they suffered many of the same adverse childhood experiences that she did. And so the story of my extended family isn't much different from our own. 5 of my cousins are my age, and they went to residential school. Some of them are younger than me. At least 20 of my cousins have been in foster care or had their children in foster care. 3 of my cousins were murdered before they were 25. 2 of my cousins have mothers who are missing and murdered Indigenous women. 1 of my nephews recently died in a fentanyl overdose. 5 others survived fentanyl overdoses. And so throughout my career, I've sought to understand, why are families so different from everyone else's? What is wrong with us? Well, in 2016, a brilliant young man, well, brilliant back then, led a study of Indigenous health high needs service users in addictions to mental health. And this is kind of a weird graph, but that inner ring represents childhood. The middle ring represents their teenage years, and the outer ring represents their adult years. And these people were high needs service users, predominantly homeless individuals with multiple episodes of care in either addiction or mental health inpatient units. So it's no surprise that there were adverse childhood experiences in childhood. But what's interesting is that trauma exposure in most cases increases with age, doesn't decrease. And at the time, we thought it was as bad as it can get. These numbers getting higher and higher as people get older and older. Then we interviewed 100 high needs service users who were incarcerated. And as you can see, the levels of trauma exposure were more than double the high needs service users in some categories. 98% indicating they had a substance abuse problem. 95% indicating they suffered from anxiety, depression, suicidal ideation, panic attacks, PTSD, insomnia. Of the 200 people we interviewed, 41% of them were residential school survivors. 75% of them had a parent or parents who had attended residential school. Many of these people were survivors of the 60s scoop or had grown up in multiple foster homes as children. Many of these people recalled the loss or disappearance of a significant female figure in their lives, stories of missing and murdered Indigenous women. But all of the men and women that we interviewed have or had children who were at the time growing up without one of their parents or both of them. So we know that ACE scores increase the prevalence of health risk behavior, and we know that more ACE scores push that risk of chronic health conditions even higher. Yesterday, I did this presentation at York University, the Osgood School of Law, and I had a blood pressure monitor attached to me. And it disrupted my presentation because it was buzzing and vibrating every 30 minutes, taking my blood pressure. And I've done this presentation about 20, 30 times now. And I've always saw myself outside of these statistics, some sort of an exception to the rule. But then it dawned on me during the presentation that, people with high ACE scores, as you see in this chart, have a higher risk of heart attack and heart disease. I had this kind of cardiac event right before New Year's. And so for the first time, I actually saw myself in these statistics. And it's a scary thing to see. And, it made me realize that, you might outrun your history, but your biology and your physiology will always catch up eventually. But is it all about trauma? No. In most cases, trauma starts the fire in Indigenous health, but it's the social determinants of health that keep that fire burning. What are the social determinants of health? Well, the social determinants of health are those conditions and the places that we live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. according to the Center for Disease Control and Prevention. Typically, we're talking about food security, income, education, employment, housing, healthcare, and ultimately social community context. So when we have good determinants of health, we have lower health risks and we have better health outcomes. And when we have bad social determinants of health, we have bad health outcomes. Simple, right? Well, 25 years ago, the Royal Commission on Aboriginal People raised the alarm on the poor social determinants of health and poor Indigenous health outcomes. They begged the government of Canada to do something about it. So let's see how much things have changed in 25 years. Well, in 2019, the proportion of Indigenous people with moderate or severe food insecurity was more than double that of the overall population of Canada. In 2015, Indigenous people and Indigenous communities are age 15 and over had a median income of just $16,000. This is approximately half the median income of non-Indigenous Canadians at $34,000. Poverty is a barrier to health services, and putting food on the table for your kids is always going to take priority over seeing a doctor that's 200 kilometers away. Poor education and training opportunities affect Indigenous health. Unemployment rate for people living unemployment rate for people living on reserves is 3 to 4 times higher than non-Indigenous Canadians. 31% of people living in Indigenous communities were considered low income, compared with only 11% of non-Indigenous Canadians. Safe and adequate housing affects Indigenous health. In 2021, 37% of people in Indigenous communities lived in homes requiring major repairs. Poor air quality and black mold contribute to higher rates of respiratory disease, COPD, and asthma. In 2021, 36% of people in Indigenous communities lived in crowded homes, compared to only 9% of non-Indigenous Canadians. Overcrowding contributing to an alarmingly high rate of infectious diseases in Indigenous populations. And so with this in mind, we begin to understand just how dangerous COVID-19 was to these Indigenous communities. According to the federal government, there are now more than 100 drinking water advisories still in place for First Nations across Canada at any given moment. And it is any wonder that the rate of waterborne diseases in Indigenous communities is 26 times higher than the national average. This is the chief of Little Saskatchewan Reserve in Manitoba. And a Health Canada staff member told him this water is fine to drink, but a private lab told him not to bathe his dog in it. This slide, a little bit more salient to myself, the Heart and Stroke Foundation of Canada states that heart disease rates for Indigenous people are as much as 50% higher than non-Indigenous Canadians. And the death rate from stroke is twice as high. In 2018, the Indigenous rate of diabetes is almost 2 times higher than the national average. In 2018, Indigenous rates of tuberculosis are 34 times higher. Inuit populations, 290 times higher. So an age standardized hospitalizations rates for people living on reserve is 2.7 times higher for females and 2.4 times higher for Indigenous males. And then we get into mental health. The mental health the mental health hospitalization is 3 times higher for non-Indigenous. The rate of hospitalization for intentional self-harm, 7.3 times higher. The rate of suicide is 3 times higher, but we know there are communities where it's as high as 25 times higher. Like, there's an Indigenous community here in Alberta that had 70 suicides in a 4-month period a couple of years ago. Right now in Alberta, the rate of Indigenous opioid deaths is 7 times higher than non-Indigenous populations. So in 2016, Alberta was in national news when it was discovered Indigenous Albertans were living 12 years less than non-Indigenous populations. It was on every major news network across the country. Well, today, life expectancy is 18.2 years shorter for First Nations persons in Alberta. And as recent as 2016, the Indigenous infant mortality rate is still twice as high as non-Indigenous Albertans. Things are not getting better, they're getting worse. Well, what does all this translate to in terms of health outcomes? Well, it means Indigenous people have shorter life expectancy in Canada. And so some people are reluctant to call this an Indigenous health crisis. Well, you're sensationalizing the concerns, Randal. Or they're reluctant to call it a violation of basic human rights. I just don't know how anybody could look at a group of people living 10 to 18 years less than the rest of the population and regard it as anything but. So how do we move forward as health services? And how do we move beyond what I'm calling the Indigenous health crisis? Well, the first thing we need to do is remove the biggest and oldest systemic barriers to healthcare there is. And which barrier is that? Well, you only need to look at the newspaper headlines to answer that question. Brian Sinclair died in a Manitoba emergency department. A double amputee in a wheelchair who's presumed intoxicated and told to go away. He dies of sepsis sitting in the emergency department, and his body is discovered 34 hours later with rigor mortis. There's an emergency room in BC that was playing Price is Right, placing bets on the blood alcohol level of Indigenous patients. A young Indigenous woman almost died when she was presumed intoxicated, but was actually found to be severely dehydrated. A few of us will remember AHS staff being fired a few years ago for racial slurs directed at a leader of an Indigenous community. Then we have the McLean study here in Alberta that looked at 11 million emergency room visits. They found Indigenous patients were consistently triaged as less urgent than non-Indigenous patients who had the exact same diagnosis. Of course, there's the tragic death of Joyce Echaquan in Quebec, where she filmed nursing staff saying horribly racist things to her as she died. A few months after Joyce's death, 2 more nurses were fired after Jocelyn Ottawa went to a clinic for wound dressing on her foot. The nurses humiliate her, saying they prefer to call her Joyce. They demanded Jocelyn sing songs for them in her native language. She then realized that they had taken her phone away and were withholding it for the duration of the appointment. These are stories that point to a national problem of systemic racism in healthcare. In fact, the federal health minister, Patty Hajdu, attended a public forum following the death of Joyce Echaquan and said, "This is not shocking to me. Racism is not an accident. The system is not broken. The system was designed this way, and the people in the system are incentivized to stay the same." But maybe this is all just mainstream media, right? Maybe they're just trying to sell newspapers. Well, numerous independent investigations and commission reports have confirmed it in the past. The TRC report comes out in 2015 outlining numerous systemic Indigenous health inequities. First People's Second Class Treatment comes out in 2015, an independent study by the Wellesley Institute. Out of Sight report comes out in 2017, examining the death of Brian Sinclair. Key Health Inequalities in Canada, a national portrait, is released in 2018 by PHAC. And it actually said, if there were no inequalities between people living in areas with low and high concentration of Indigenous groups, there would be a life expectancy increase between 9 and 17%. And just think about that for a second. If the Indigenous people in your community did not face health inequalities, the life expectancy of your community would increase by 9 to 12%. The Vines report comes out in 2019 in response to Joyce Echaquan's death. In Plain Sight comes out in 2020. It surveyed 9,000 Indigenous people, 84% of whom indicated they experienced racism in healthcare. But this is all fairly new, these reports and all these discoveries. No, the RCAP report, as we talked about previously, came out 36 years ago. The final report, 5 volumes, 3,347 pages, documenting discriminatory government policy in Canada. And in 2016, 20 years after its release, a 72-year-old Paul Chartrand, who's one of the original commissioners, is quoted as saying, "There's a powerful lesson in all this. And that is to say, today, I don't think anything has changed." Systemic racism and discrimination contribute to a lack of trust. It can make patients feel unsafe, even afraid to seek health services. The rate of acute admissions in Indigenous populations is rising, and the rate of primary care access is dropping. This means they're accessing healthcare only when they absolutely have to. This means that small treatable health problems are turning into chronic health problems, which eventually lead to poor health outcomes and in some cases, early death. So where do we go from here? Well, Canadians need to understand that colonization was designed to displace and disconnect Indigenous people from their communities, their families, and their culture. They need to understand that the health inequalities, health inequities experienced by Indigenous people represent the embodiment of that structural and systemic disadvantages that were installed through colonization. They need to understand that the poor Indigenous health outcomes are not an accident. The colonial system was designed to oppress, and the poor health outcomes are a direct result of that oppression. So to reverse these inequities, we need to decolonize health services. But what is decolonization? Well, Dr. Linda Tahiwai Smith literally wrote the book on decolonization in 1999. And she said, Indigenous decolonization describes the ongoing theoretical and political processes whose goal it is to contest and reframe narratives about Indigenous community histories and the effects of colonial expansion, cultural assimilation, exploitive Western research, and often, though not inherent, genocide. Dr. Smith is a Maori from New Zealand, and my wife is a Kiwi from New Zealand. So if she's watching today, I might actually score some points with that quote there. But anyways, what does it look like in practical application? What does it look like in terms of healthcare system reform? Well, the first step to decolonizing healthcare requires acknowledging the legacy of colonialism in healthcare and the truth and the consequences of it. Then it requires collective action, not commitment, action, to identify and remove colonial systems that continue to act as barriers to adequate Indigenous healthcare. This means removing and replacing policies and procedures that create healthcare disadvantages for Indigenous people. It means addressing racism and discrimination on a systemic level, which means staff will need to leave. Rotten apples will fall off growing trees. We need to accept that reality instead of protecting the status quo. Finally, it means working with Indigenous communities to find healthcare solutions that work for them. And when I talk about this, people always ask me, you're talking about healthcare reform on a massive scale, and it's going to cost money. Who's going to pay for that? And I quite often will say something like, the same people who paid the $40 billion settlement when the federal government was found to be willfully discriminating against Indigenous children in the child welfare system, or when it was found to be discriminating against Indigenous people in terms of clean water access. See, as a country, we're slowly learning that doing the right thing comes at a cost. Systemic change comes at a cost. But so does discrimination. So does willful ignorance, and so does complacency. Our elected officials need to understand that we can do the right thing now and pay a little bit, or we can continue to do the wrong thing now and pay a lot later. And this will never be a priority for our politicians until we tell them it is. So where do we start? Well, there can be no steps towards decolonizing health without the implementation, without starting the implementation of the TRC's health calls to action. People quite often talk about the calls to action, the TRC, but very few people have actually picked up the document and read it. So let's briefly go through the health calls to action here so you get a sense of what I'm talking about. Talking about implementing the treaty right to healthcare. First Nations, Métis, and Inuit people have constitutionally entrenched rights to healthcare. And while Treaty 6 was the only treaty that contained a medicine chest clause, there is evidence to suggest many other treaties held oral agreements for the same provisions. Modern legal scholars have interpreted the medicine chest clause to mean access to medicine and healthcare in modern times. It talked about establishing goals, a measurable action plan with key performance indicators. That doesn't seem like anything too crazy. Talked about recognizing distinct needs of Indigenous people. All Indigenous people have distinct needs. Cree, Blackfoot, Dene, Inuit, on reserve, off reserve, all different, all distinct, and they need to be treated accordingly. Talked about funding for healing centers, sustainable funding for healing centers to address the legacy of residential schools. You know, after Kamloops 211 everybody was just pouring their hearts out. If only there was something we could have did for those children. There are 12,000 residential school survivors walking the streets of Alberta right now. And they should have access to Indigenous healing centers that understand their trauma and pain. We can do something for those children. Recognize Indigenous healing practices. Yes, health services should facilitate access to Indigenous healing practices upon request. Talked about hiring more Indigenous health professionals. Yes, Indigenous trust in healthcare is broken, and it can be rebuilt with the help of Indigenous health professionals. Finally, he talked about medical and nursing school curriculums, absolutely critical. You know, before Kamloops 211, I did a presentation to about 50 psychiatry residents at Alberta Hospital. Some were from Alberta, many were from different countries. And I asked, how many of you guys know what a residential school is? And about 3 people raised their hands. So we're never going to get to a place where we can improve Indigenous health outcomes and until all health professionals are familiar with the traumatic history of Indigenous people in this country and the unique healthcare needs they have as a result. So we're talking about expanding education awareness of Indigenous health. And I'm talking about moving beyond cultural competency and online learning modules. I'm talking about, you know, the role of trauma and the role of Indigenous social determinants of health, and ultimately the current Indigenous health crisis context. Talking about trauma-informed care implementation, and ultimately a comprehensive strategy to address racism and discrimination in healthcare, even in addressing unconscious bias. There's much we can do in that education and awareness piece. And here I'm talking about Indigenous data. Decolonizing health services means health services may need to change. And we need to challenge the belief that healthcare services are static and embrace the reality that health services are constantly changing and may need to change faster. And so may we. When we talk about data, we look at the Indigenous health data that we collect. We get a clearer picture of the health needs and the scope of the health problems. Harnessing the power of data ensures that services will be designed for maximum benefit and impact. And we need to do so in partnership with Indigenous communities in a way that's OCAP compliant: ownership, control, access, possession. Indigenous program development and research. Let's talk a little bit about that. There's this theme of discrediting Indigenous strength-based, community-focused research in many academic institutions or in the academic arena. The literature reviews will all say something like efficacy inconclusive, further research is needed, or random control trial recommended. Well, we need to move away from these problematizing Indigenous peoples towards a focus on strengths, resilience, and capacity building. We need to start looking at Indigenous program development and research in a way that's conducive to Indigenous health, culture, and identity. And we need to think beyond reflexivity and challenge the very structure of Western-based research agendas in order to reframe and decolonize program development and research. The very term, if you really think about it, the very term best practice is at odds with Indigenous culture and values. Best practice implies one approach is better than the other. Well, Indigenous culture and wisdom would never keep score on something as important as health. All approaches to help those in need would be regarded as valuable or helpful to healing. Best practice is subjective. It's rooted in values, worldview, perception, what we perceive as valuable. Best practice here might recommend targeting the most vulnerable people in the community and those identified as most vulnerable in this non-Indigenous community, and those identified as most vulnerable in a far north remote Indigenous community might be 2 completely different populations with 2 entirely different needs. And so there's this recent Indigenous push to adopt the term wise practice in reference to programs that have proven helpful to Indigenous populations. And this really speaks to the fundamental ways valuable Indigenous research is being led within an Indigenous perspective. And so we also need to, thinking about research a little bit further, we need to emphasize the value of qualitative data in Indigenous program development and research. Indigenous culture, it has so much of its identity rooted in oral tradition. It only makes sense to consider individual stories and experiences in program development and research. It should not be regarded as a credibility deficit, but as a strength. This also speaks to the value of user experience in program development. The IPJ projects I did in 2016 taught us that Indigenous service users will only go to the services that deliver services in a way that works for them, even if it means not getting any services at all. So it's imperative that we're not just listening to service users, but we have to learn from them too. Building resilience through culture and spirituality. In the same IPJ projects, we interviewed 200 Indigenous people who had accessed addiction treatment multiple times. And we asked them, which factor influenced your sustained recovery the most? Well, 22% said, it was family and friends that finally got me sober. 22% said it was going to the treatment program was really good. But 35%, by far the biggest percent, said finding culture and spirituality was what sustained the recovery the most. So doesn't it make sense that we build on that strength in our program development and our research? Ethical space. Ethical space of engagement proposes a framework as a way of examining the diversity and positioning of Indigenous peoples and Western society in the pursuit of a relevant discussion. It's absolutely critical when we talk about the conversations that need to happen in terms of health partnerships between Indigenous and non-Indigenous communities. And of course, Dr. Albert Marshall's two-eyed seeing approach here, which consists really of seeing with one eye the strengths of Indigenous ways of knowing and being, and with the other eyes, the strengths of Western ways of knowing, and using both of these eyes together. There's a funny story that comes to mind when I think about two-eyed seeing, and that was a bunch of researchers, federally funded Canadian researchers, go up far north to look at these declining whale populations. And they're looking around, they're flying around this helicopter, they can't see any whales. And it's true, the whale populations are in fact declining. It can only be over harvesting by the local Indigenous populations. Let's go down and talk to them. So they go down and talk to them and say, where are all the whales going? Why are there no whales? The Indigenous population kind of look at each other and they say, what are you talking about? There's more whales here than we know what to do with. They're all hiding because they're scared of your helicopter. And so if we begin to look at things with a two-eyed seeing approach, if we're developing programs and policies and research models in partnership with Indigenous populations, we'll see something that we're not seeing with our one eye, but we'll see things with a two-eyed seeing approach. Supporting Indigenous communities. This is a picture of me signing a multilateral health MOU with Enoch Cree Nation. It was signed by 4 levels of government. People flew in all the way from Ottawa to sign this document, but it established a partnership in Indigenous healthcare. And this is what we need going forward. We need to be replacing prescriptive and paternal funding mechanisms with Indigenous health partnerships and collaborations that are based on mutual respect and understanding. That's where the saying comes from. Nothing about us without us. Government grants often say, you need this program. We'll write us a proposal and maybe we'll fund it for you. Well, here's the problem with that. A community's needs shouldn't be determined by a government bureaucrat 400 kilometers away. It should be determined by the community that's struggling to meet its needs. Talking about supporting a shift from crisis response to upstream prevention. There's very little support for Indigenous prevention these days. It's getting better, but it still needs plenty of improvement. And we need all levels of government back at the table to be looking at sustainable prevention funding, not just grants. Because as we so often say in health, prevention is always better than the cure. And so the trauma of losing your culture, your language, your identity, the trauma of neglect, emotional, physical, and sexual abuse, coupled with the loss of parental role modeling. Many Indigenous people who were abused and neglected in residential schools went on to abuse and neglect their own children. Many of those children had their children taken away from them, and the cycle of Indigenous trauma repeats itself. There are now more Indigenous people incarcerated in Canada than there were Black people at the height of South African apartheid. There are now more Indigenous children in foster care than were ever in care at the height of residential schools. Indigenous youth are one of the fastest growing segments of Canada's population, and they're also near top of the list of Canadians most likely to die young. So the need for active steps towards reconciliation and health isn't going away. It's growing exponentially. And now it's easy to hear all these heartbreaking realities and become overwhelmed with the sheer scope of the problem, to feel sad, angry, or even to lose hope. But I assure you there's much to be hopeful for. The recovery in Kamloops and Cowessess shocked the country, and there are now active ground penetrating radar searches underway all across Canada. And what we need to understand is that the voices of these children have been heard, and they've woke up a sleeping giant. From coast to coast and around the world, people were standing up and they were speaking out, and they were saying, every child matters. Many Canadians were seeing and hearing that truth for the first time, and so the journey to reconciliation can begin. This is a quote by Senator Murray Sinclair, and it's etched in the wall of his law school. And it says, "The road we travel is equal importance to the destination we seek. There are no shortcuts. When it comes to truth and reconciliation, we are all forced to go the distance." And I just love that quote. I think it speaks volumes to the fact that we're all in this together and everybody has to play a part. Which brings us to your part, what you can do. And what difference can I make? What can I do? Well, you can help others to understand, to recognize that the Indigenous health crisis is a human rights issue. And we've done study after study for 25 years, and they've all concluded with the same thing. We need action beyond inquiries and political lip service. And that only comes when we recognize Indigenous health inequity for the human rights violation that it has been and continues to be. Can help others understand the importance of trauma-informed care and the role of social determinants of Indigenous health. You can be an ally. You can stand up and speak out against racism wherever and whenever you see it. And being an ally means being an ally all the time, not just in the boardroom and not just when you're standing at the podium. You can identify opportunities in your organization to decolonize health services for Indigenous patients. You can consider developing your own reconciliation action plan. And you can help build Indigenous trust in healthcare and make the healthcare system a safe place for Indigenous people. So apologies for using this picture 3 times. It's actually one of the very few pictures. I think I have 3 pictures that remain from my turbulent childhood. You know, the human brain is remarkable, and it will do everything it can to protect you from trauma. And I remember my trauma from my childhood like it happened yesterday. But my little sister remembers nothing of her childhood. Her brain has hidden the trauma so well that even her good memories are gone. In the beginning of this presentation, I told you about my mother and trauma she experienced as a child. Then I told you about the trauma her children experienced. So where are they now? Well, both my sisters have long histories of dysfunctional relationships and domestic violence. Both of my sisters have been to addictions treatment more than once. Both of my sisters have had their children taken away and placed in foster care one time or another. One of my sisters has lost a child in the opioid crisis. And we've all had or continue to have struggles with physical health, mental health, substance abuse, and the criminal justice system. And you drown not by falling into a river, but by staying submerged in it, quote by Paulo Coelho. particularly salient when I think about my life. And, escaping the trauma of our childhood has been difficult for all three of us. And some of us do remain submerged. But throughout the course of my adult life, I've learned many things. I've learned that healing is this lifelong process. Some days are harder than others, but it gets easier over time. I've learned about the power of unconditional love and the healing of forgiveness. And like my mother before me, I too found a way out. I followed her footsteps through university and built a career that has taken me around the world. And like my mother too, I achieved many of the dreams I once thought impossible. Once an angry and violent young man, I'm now a warm and loving father who's built a safe, happy, and healthy home for his family. And the Indigenous cycle of trauma may not stop with my sisters and their children, but it'll certainly stop with me and mine. So Indigenous Truth and Reconciliation is not an attempt to make you feel guilty, nor is it an effort to instill you with a sense of shame. Shame is the enemy of reconciliation because shame replaces conversations with silence. Indigenous Truth and Reconciliation is not a cry for sympathy or pity. Indigenous Truth and Reconciliation is a plea for understanding. And without conversation, there will be no understanding. And without understanding, there will be no action. So please understand that you have an important role to play in the Indigenous reconciliation, but it is up to you to discover what that role will be. I'd like to leave you with a final thought on the traumatized mice and the cherry blossoms. I mentioned at the beginning of this presentation, the mice and the cherry blossoms. Well, when the traumatized mice were sprayed with the cherry blossom scent without the electric shock, they eventually stopped reacting to it. Their brains had rewired the response to the point that their sperm no longer held that epigenetic signature of the trauma response. Now, it's early days, but the study suggests once trauma is removed from the equation, traumatized brains can be reprogrammed. So we no longer live in fear. Well, maybe we can recover from trauma to the point that it disappears from our DNA. Maybe as health professionals, we can help stop the cycles of Indigenous trauma from being passed on to the next generations. And maybe as health professionals, we can ensure the next generations have greater health equity so that we can all move towards reconciliation, not just as individuals and families, but as friends, neighbors, and communities. I want to thank you all for being here today. And I want to thank you all for listening. Kinana skumit nan, hi hi.